Good evening to everyone. I'm your host and MC, Deputy Consul General Victorio Dimagiba Jr. for tonight's webinar entitled Breathe, a webinar on lung cancer awareness, brought to you by the Philippine Consul General in Calgary in cooperation with our partners from the Alberta Health Services. We are happy that we have over 35 participants this evening who are joining us via the Zoom platform. Before we begin, some housekeeping rules. Please remain muted during the duration of the webinar. Questions are welcome to be raised using the Zoom chat box, and which will be read during the question and answer portion. When writing your question, please identify yourselves and to whom the question should be addressed. May we now call on Consul General Zaldi B. Patron of the Philippine Consulate General in Calgary to deliver his welcome remarks. Consul General Patron, please.
Maraming salamat, Deputy Consul General Vic Dimagiba. Good evening to all our participants from Alberta and Saskatchewan and other parts of Canada. It is my pleasure to welcome you all tonight to our webinar titled Breathe, a webinar on lung cancer awareness. We are organizing this activity in cooperation with the Alberta Health Services as part of the Philippine Consulate General in Calgary's Gender and Development Program for 2022, and in observance of the Lung Cancer Awareness Month held every November all around the world. We have partnered with the Alberta Health Services for tonight's webinar, and I would like to thank Ms. Nadine Strilchuk and Mr. Gordon Cleaver, who will serve as our resource persons. According to the World Health Organization, cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, or about 1 in 6 deaths. Lung cancer is one of the most common types of cancer in both men and women. In the Philippines, cancer is the number 2 cause of mortality according to the Lung Center of the Philippines, and lung cancer is the most common form of cancer in the Philippines. It is also the type of cancer with the number 1 cause of mortality, wherein the average lifespan of a person diagnosed with a lung cancer is only 3 to 6 months. The Global Cancer Observatory published that in 2020, 19,180 Filipinos were diagnosed with lung cancer, with 5,774 new cases among Filipino women. Survival of patients with lung cancer is stage-related, so there is a greater advantage of survival if lung cancer is detected and treated early. We at the Philippine Consulate General believe that it is important for the Filipinos in Canada to be aware of the symptoms, treatments, and early detection methods or screenings for lung cancer. We have decided to host this webinar as one of our activities under our Gender and Development Program, as women unknowingly, by the nature of their task at home, are exposed to various elements and chemicals from beauty, cooking, and cleaning products to substances on the clothes of their family members. In addition, they are also exposed to everyday pollution and other substances they come into contact with at work. Any of those elements and chemicals, including smoking of tobacco, can contribute as risk factors to lung cancer. It is important for our Filipino women to be informed so that they can take the necessary steps to take care of their health and the health of their family members. We hope that after this webinar, our participants will be our partners in sharing with their own family and friends the useful information they will gather from this webinar. Our goal is for all of us to become more aware and conscious of our health. May we have a productive and informative webinar. Maraming salamat po.
Thank you very much, Consul General Patron, for your kind words this evening. And now, To begin our webinar, I'm honored to introduce our two speakers for this evening from the Alberta Health Services. Our first speaker is Ms. Nadine Strilchuk. She is a graduate of Bachelor of Science of Nursing, and Ms. Strilchuk has worked as a registered nurse in internal and pulmonary medicine, rural medicine, and palliative care. Her love for direct patient care and her desire to provide greater knowledge and expertise to her patients facilitated her decision to return to school and complete her Master's of Nursing in 2009 at the University of Calgary, earning her CNS designation. She followed this up in 2010 with a postgraduate nurse practitioner diploma and has been a member of the Alberta Thoracic Oncology Program until the spring of 2022 when she joined the Alberta Lung Cancer Screening Program. Our second speaker is Mr. Gordon Cleaver. He is an expert in change management and quality improvement with the successful implementation and administration of multiple provincial projects. Mr. Cleaver has worked in screening programs for over a decade and has been committed to collaborating with teams and specialists, deploying a synergistic approach to leading complex projects with high levels of interdependency and risk. He has both knowledge and experience in managing community engagement in public health projects and in creating successful partnerships with key internal and external stakeholders. Mr. Cleaver has an undergraduate degree from the University of Victoria and a Master in Nursing and Advanced Nursing Practice from the University of Athabasca. His current position is as Senior Advisor for Special Projects for Provincial Population and Public Health. I now give the floor to Ms. Strilchuk and Mr. Cleaver for your presentation. Please.
Thank you. So we'll share the screen with you. Just give me a second to set myself up. Okay, so everyone can see my screen?
It's good.
Okay, good enough. I'm sorry, I didn't hear anything. So I'd like to start the presentation by letting you know we're going to have two parts to this: lung cancer and sort of the ins and outs of that, and then the importance of screening. And we'll go through the details as we go along. And myself and Gordon will co-present. And if you're more comfortable turning your cameras off, please feel free to do so and just relax. And I hope you enjoy the presentation this evening. So before we get started, I'd like to acknowledge what we call Alberta is the traditional and ancestral territory of many peoples, presently subject to Treaties 6, 7, and 8. We acknowledge the many First Nations, Métis settlements, and Inuit who have lived in and cared for these lands for generations. We're grateful for the traditional knowledge keepers and elders who are still with us today and those who have gone before us. We make this acknowledgement as an act of reconciliation and gratitude to those whose territories we reside or are visiting. The screening program itself is sponsored by Canadian Partnership Against Cancer in the form of a grant, as well as the program received in-kind assistance from Alberta Health Services in the form of support for the working groups, as well as the IT group, project evaluation research teams. Both Gordon and I have no conflicts of interest, and we do not receive any direct honorarium. So I have quite a few topics that I was asked to cover. So perhaps I won't spend too much time on this page, other than I will try to give a panoramic view of lung cancer and then talk about maybe how we can start making changes. So as Consulate General has already said, lung cancer is the most common cancer worldwide and accounting for more than 2 million new cases and 1.7 deaths in 2018 alone. In Canada, over 21,000 Canadians each year will die of lung cancer, more than breast, prostate, and colon cancer combined. And only in a 5-year survival, only 17% will be living. Whereas with prostate, you'd see about 95% of people living in 5 years and 88% of those with breast cancer. So lung cancer is the most common cancer and is also the leading cause of cancer death in Canada. So when we think of Alberta specifically, you can see on this graph, the bar for lung cancer is very large. And this is not just in Alberta, this is across the country and across the world. So women and men are pretty equally distributed for contracting lung cancer. And you can see again, this just also emphasizes again that it's more frequent than the other cancers combined. When we look at incidence rate, this graph is a very quick depiction of, although smoking cessation rates have come down for both men and women over time, this graph demonstrates, though, the lung cancer diagnoses and continue to climb and will be ongoing past the year 2030. Part of the reason is we have an aging population, and we know the longer we live, we have a higher risk of developing lung cancer, as well as people that were previous smokers that are higher risk as well. So just a little kind of cancer 101. So cancer is a disease of cells in the body that have decided to no longer obey or listen to the guidance and control of our normal processes. I sometimes liken cancer cells to really bad teenagers that no matter what you tell them, they're just not going to listen. So, and cancer cells are no different. And what's unusual about cancer cells is that they can actually almost put up camouflage so that we can't actually know that they are existing in the body. So our body doesn't recognize that they're actually there before a symptom might occur. So, and when the lung cancer, or when cancer starts in the lung, it's called lung cancer. And lung cancer, we know, can begin in the lungs and spread to other parts of the body. When it spreads to other parts of the body, this is called metastases. So there's two main types of lung cancer. There's non-small cell lung cancer and small cell. 80 to 85% of all lung cancers are small cell or non-small cell. And non-small cell can, people who smoke or have never smoked can get non-small cell. Generally, with non-small cell lung cancer, adenocarcinoma is the primary type, accounting for 40% of cancers. And within that 40% window, we know that this is the type that never smokers can get. Generally, they don't get squamous cell carcinoma or large cell just simply because they're more associated with smoking. Small cell cancer, on the other hand, we know that 10 to 15% of lung cancers are caused by a small cell. And often it used to be called oat cell. And the reason being is if you think of, if you sow your field with oats, there's always oats in the neighbor's yard. So small cells like that, it spreads very fast and it grows quickly. And this one's associated primarily with smokers. And in fact, if we get a diagnosis of a small cell lung cancer in a non-smoker, we often have to dig a little deeper because it'd be very unusual. We know that 80 to 85% of lung cancer deaths are caused by cigarette smoking. We also know that tobacco products such as cigars and pipes can also increase risk. There's more than 7,000 chemicals in cigarettes or in tobacco, and 70 are known to cause cancer. There's 70, and there's probably more than that. That's what we're aware of. If you smoke, you're 15 to 30 times more likely to get a lung cancer. And the number of cigarettes you smoke, as well as the years that you smoke, increases your risk. So the key thing would be quitting smoking, as it lowers your risk, but you'll never get quite back to that of a never smoker. But quitting smoking at any age is preferable than to continue to smoke, because not only does smoking cause lung cancer, it also causes other health issues like COPD. Another way of thinking about that is emphysema, coronary artery disease, stroke. So there's a lot of good reasons and compelling reasons to quit smoking. Smoking is actually one of the leading preventable cause of death. So 12% of all deaths worldwide are caused by tobacco. And in fact, one death occurs every 6 seconds. It is expected that over 1 billion people in the world will die from tobacco-related deaths in this century. And again, that expands out further than lung cancer to other diseases as well. The second greatest risk for lung cancer is actually radon exposure. And radon is an invisible, odorless, tasteless gas that comes from the ground, and it causes lung cancer. 16% of lung cancers in never smokers have been attributed to radon exposure. And radon exposure is preventable, and I'll explain that on another slide. The other factors that you have to think about is secondhand smoke, workplace exposures such as asbestos, arsenic, silica, or chromium. And the risk is even higher if you smoke. And then air pollution, as it's already been mentioned, and a personal or family history of lung cancer can also increase your risk of developing lung cancer. So how can you reduce your risk? Number one, quit smoking if you smoke. Avoid secondhand smoke if at all possible. And then get your home tested for radon gas. And in fact, what they'll do is they'll come in and they'll actually test your home for the levels and see if your levels are quite high. And if they are, they can remediate your home for that. Generally, how you do this is you get a hold of a radon kit. I put a little website on there that might help you locate how to find a radon kit. And it comes to your home, and it's kind of like a very, very small black hockey puck. You put it in your basement in the room that's most commonly used by your family. It's there in the winter months when our windows are closed. And after 3 months, you mail it in, they'll evaluate your home for radon. And if in fact you have high levels of radon, then they'll offer solutions of how to actually manage this. Unfortunately, Alberta actually has a high radon content in their soil, and it's more common than we'd like to know or think about. Also, when you're working, if you're working with hazardous chemicals that could be possibly cancer causing, wear appropriate protective gear to keep yourself safe. So lung cancer spreads through tissue where it'll start growing in an area and then start to spread out. It can spread through the lymph system as well as the blood. Typical places for lung cancer to spread would be the bone, the brain, the lymph system, the adrenal glands, the liver, and other parts of the lung. Symptoms would include coughing that gets worse or won't go away, chest pain, shortness of breath, wheezing, coughing up blood, feeling very tired all the time, weight loss with no cause. And the challenge with a lot of these symptoms is other diseases can cause these symptoms. So these are not exclusive symptoms to lung cancer. For instance, coughing, you know, if you have a cold, you're going to cough, and sometimes you have a prolonged cough. But if you're concerned about it, you should see your family doctor to see if you can get some additional investigations. Chest pain, as you know, can be associated with a heart attack. So a lot of these symptoms are very vague, but important to pay attention to. So how do we diagnose lung cancer? So common investigations used for lung cancer workup would be a chest CT scan. That's usually what happens is you'll see your family doctor. They'll give you an X-ray, a chest X-ray. If they feel that there's a concern on X-ray, then they'll go ahead and order a chest CT scan. The chest CT scan is a very detailed look, and it might flag that there is a concern. Blood work may be helpful, but not so much in diagnosing lung cancer itself, but it can tell us if the liver is struggling and there's other areas of the body that we need to pay attention to and be worried that lung cancer could have already spread there. PET CT scan, which is represented by this graph, what it does is it's a special radioisotope that that's injected into your blood vessel, and it circulates your whole body and attaches itself to rapidly turning over cells. And for instance, when I look at this picture, these are your kidneys, and it's a very active organ, right? We make urine all the time, and our kidneys are always working. Whereas in the lung, we'd expect no activity. And what they're trying to show you through this image is that this little spot here and these little spots, those are lymph nodes and that are being picked up by PET scan. The graph at the bottom shows another kind of test called a specialized bronchoscopy, where they go in with a specialized camera and they can sample all the lymph nodes, which again are represented by these small little white oval structures. Pulmonary function test is also important if you're getting worked up for lung cancer, because it helps to understand how healthy your lungs are. And then a bone scan may also be utilized in trying to determine if there's any kind of cancer spread. So when we think of staging lung cancer, non-small cell lung cancer, which again includes adenocarcinoma, squamous cell carcinoma, and large cell, are by stage. So we have stage 1, 2, 3, 4. So stage 1 tells us that the tumor is just inside the lung itself. Stage 2 says the tumor is inside the lung and may also be impacting a few lymph nodes within the lung itself. Stage 3 would be where it has spread throughout the lymph system and has moved a little further out, and it may also be kind of traveling elsewhere. And stage 4 would be where it's in the lung, it's in the lymph, and it's now moved to other organs such as the brain, the liver, the adrenal glands. Small cell lung cancer is a little different. Small cell, it is staged by limited or extensive stage. And part of the reasoning for that is because small cell is kind of its own entity, and how it's treated is different. For example, if you have limited stage small cell lung cancer, the oncologist may consider providing radiation to this area. They have to be very careful of important organs like the heart or the pulmonary artery, that they don't do any damage. But if they can radiate, they will. But once the cancer travels out to other organs, then unfortunately radiation is not possible, and they would talk about chemotherapy or a chemotherapy type of agent. So when we think of early stage cancer, or pardon me, when we think of treatments for cancer, there could be a number of possibilities, including surgery, chemotherapy, radiation therapy, targeted therapy, and immunotherapy. The stage of lung cancer will dictate the type of treatment. People with small cell lung cancer are treated with radiation and or chemotherapy. They are not considered surgical. So in early stage lung cancer, the main goal is to think about surgery to completely remove the tumor or cancerous tissue. Surgery is the most effective at completely removing the cancer at an early stage when the cancer is very localized, meaning that it has not spread to other parts of the lung or body. Ideally, we would like to see all patients be eligible for surgery. However, that's not always possible, even if they have early stage disease. And part of that would have to do with patient's health. So if they're not healthy enough to withstand surgery, because it's a big surgery, then we'd have to consider other options that are more safe for them, depending on their own health situation. So if you don't qualify for surgery, there's still other good options. One of them is called stereotactic radiotherapy, where they do very targeted radiation to the cancer cells and tries to spare the healthy cells. And that's, again, if it's in early stage. When we look at advanced stage lung cancers, we're thinking about stage 3 and 4. There's no cure for stage 3 and 4. But for stage 3, there are treatments that often can prolong your life and relieve symptoms. And in some cases, you may live upwards to 5 years, depending on your response to treatment. Again, treatment often includes in stage 3 or a combination or one or the other of radiation, chemo, targeted therapy, and immunotherapy. And, you know, we always are forever learning and growing. And I put an "and" there because we don't know what's coming in the future. With technology, we've learned so much about lung cancer that we don't know what's coming down the pipe. Like, for instance, immunotherapy has only been around for 3 or 4 years, but we've seen a huge dramatic improvement with the response of patients to treatment. Occasionally in stage 3, depending on where it's located in the lung, surgery may be considered. That is a really complex decision that they meet with the complex team, including surgeons, medical and radiation oncologists, to determine if that's something that they think they can offer. And then for stage 4 lung cancer, treatments are more for comfort and what we call palliative care, and it can include chemotherapy or radiation therapy. So when we think about gender differences in lung cancer, this is not my area of expertise, I must admit. So I did reach out to a gal named Chelsea. She's a Master of Sciences student getting ready to defend her thesis. She had hoped to be here tonight, but because she's right in the middle of prepping for her thesis presentation, she just felt that she couldn't be here. So I offered to share her slides today. So I'll do the best I can. So with this, we've already talked about the comparison between people with lung cancer to the other people with either colorectal, prostate, or breast. And you can see the difference here without me going into much detail. But I think what Chelsea was hoping I would try to explain to you today is that males have an increased incident rate and lower survival rate than females. Females tend to have a better response to surgery, radiation, and chemotherapy than males. Sex differences also occur in the response to treatment, in particular targeted and immunotherapies. So people's response to that will vary based on their gender. So why the difference? Well, there's definitely biological differences. We all know that between females and males. And types of cancers also tend to be more associated. Certain types of cancers tend to be more associated with women than men, and we know that adenocarcinoma is one of them. There's also differences in genetic mutations within the genders, and we know our bodies respond differently to nicotine metabolism, enzyme-dependent activation, and detoxification of the actual tobacco carcinogens in the cigarettes themselves. And how our body repairs is different. So that's the DNA repair mechanism and hormonal effects. And recent research has been looking at the potential relationship with estrogen and lung cancer. And many of you probably are familiar that there is definitely a relationship between breast cancer and estrogen, and now they're looking into lung cancer as well. There's also socioeconomic differences between the genders, and they did, in a couple of studies, they noticed that there was a longer diagnostic interval associated with women. But what was interesting about that, though, was even though they were diagnosed perhaps a little slower, they were diagnosed at earlier stages of their cancer than men. And it was curious that men were slightly more likely to participate in a lung cancer screening program. And they're wondering also if some of the differences between the genders has to do with occupational risk factors. I mean, the world is changing. Women and men perform very similar jobs, but in the past, we all know that men tended to be more involved in construction and more high-risk jobs that would expose them to more risk. When we think of women, in Canada, we're pretty lucky because we don't have a lot of in-our-home exposures to cancer risk, but definitely in other countries where you might be cooking in an open flame or using coal, your risk of exposure is higher just by breathing in that kind of a fossil fuel. So ultimately, there's really no clear answer how gender plays a role in most lung cancers. There's not a lot of real-world data or studies actually in Canada and across the world. So hopefully this will become more and more of a discussion as we learn more and more about lung cancer. So it's definitely something that we need to address and potentially for new treatments by understanding the different mechanisms of how our bodies differ in the way that cancer impacts us. And then also by finding out if there's more accurate ways of diagnosing and determining how long someone might live in order for patients to make a more informed treatment choice. So I would like to now kind of slide into our lung cancer screening program pilot in Alberta. I will give you a bit of updates on a few things, and then Gordon will take it from there. So it is estimated in Alberta, 1 in 7 adults currently smoke. Looking at data online for Saskatchewan, it's actually very similar because I did want to be very mindful that I did have some information on Saskatchewan. So we actually are pretty similar in all our statistics. I'm focusing on Alberta because that's the statistics I'm most familiar with. So it is estimated that approximately 107 to 125,000 Albertans are eligible for lung cancer screening. That's 1 in 13 Albertans are expected to develop lung cancer in their lifetime, and most are diagnosed in stage 3 to 4. We've already talked about it's the leading cause of death, and in Alberta, over 1,500 people in 2018 died of lung cancer, and again we expect that to rise. But saying that, there's been a lot of large random controlled trials that have looked at lung cancer screening. And what it's demonstrated is that we can see a 20 to 24% reduction in lung cancer mortality with patients getting screened with a low dose CT. So part of the pilot was endorsed by Canadian Task Force for Preventative Health Care. And they endorsed the lung cancer screening guidelines, as well as the Canadian Partnership Against Cancer. One of the goals of Alberta and one of the health strategies in the cancer care was by 2030, we want Alberta to be a place where most cancers are prevented, more cases of cancer are cured, and the suffering of people affected by cancer is dramatically reduced. So we have to think about how we're going to do that. And if we see that 20 to 24% reduction in mortality due to screening, then we really need to take it seriously, because that reduction is huge, and maybe we can actually make a big impact on that 2030 goal. There are multiple provinces that have started pilots like ours. Saskatchewan, my understanding from what I could find out, was that they're in the beginnings of developing a pilot. So stay tuned in Saskatchewan. Hopefully your pilot will be available to you shortly. And then Ontario and BC now have full-scale programs. So this slide demonstrates screened versus non-screened detected cancers. So currently we know Ontario did a survey of their cancer statistics, and what they found was 75% of their people are diagnosed in late stage disease at stage 3 and 4. Alberta is very similar to this, and I would propose that Saskatchewan is the same. But what we noticed with the studies, the Pan-Canadian study, as well as the National Lung Cancer Screening Trial, which are demonstrated here, by doing screening of patients, we can actually start to see a big shift in stage. So for instance, with the National Lung Cancer Screening study, they noticed they could have 2/3 of the people could be shifted to early stage, and with the Pan-Canadian 3/4 of the people could be shifted to a earlier stage, and basically flipping the curve. So we would see 75% of people diagnosed early stage opposed to 25% in late. So that is our hope. How are patients screened in a pilot program? Well, we use what's called a low-dose computed tomography, or low-dose CT scan. And it's an imaging test that uses a computer and puts a series of X-ray images together to create a 3D image of the organs, tissues, bones, blood, and the blood vessels. It's a low-dose scan, so it has very low risk. However, it is still something that we have to think about when we talk about lung cancer screening as well. This is the actual CT machine. It's like a big giant donut. And this is in fact an Alberta patient being screened in the scanner. They do not need to have an IV or any kind of contrast dye put in before they have their scan. There's no blood work. It's pretty straightforward because it's not a really strong dose, and we're really wanting to look at the lungs. This is just an example of what they might find in the lung that's abnormal. So this is what we call a nodule, and that's what we're hoping to pick up in a screening program. If we're going to find cancer, we hope it's small, because something like this would be surgically possible. We have some key parameters in the screening program. We're looking for people ages 50 to 74 who are current or previous smokers, and they'd have to have at least a 15-year history of smoking. We use what's called a risk-based model. So we put people through a calculator to determine their percentage risk over 6 years, and we're looking for a risk of greater or equal to 1.5%. The screening would be with an annual low-dose CT scan. Radiologists use something called the Lung-RADS-based reporting framework, which I've demonstrated kind of what that looks like on the side. And what the radiologists will do is they'll review at the imaging, they'll study the imaging, they'll write a report, and then they will give us guidance based on what they see in the lung. And the system is reported in a Lung-RADS 1, 2, 3, 4 type of thing. Once the radiologist has looked at the scan, the report is there. Myself as a nurse practitioner will review all the details and either order a scan for those that are going to go for annual screening, or actually meet with patients if they have something that we're concerned about and get them to the appropriate place. Often, most people will just need ongoing screening. Some people, though, will need potential treatment, and we send them to a clinic called the Alberta Thoracic Oncology Program. Patients that smoke will be offered enhanced tobacco cessation support. And now I'll just stop sharing my screen so Gordon can take over.
Actually, some reason I don't have this deck that's rearranged. So if you could continue.
Okay. I'm happy to do that. So why don't you just tell me to forward the slide as you need it, Gordon?
Yeah, so if you can just click the mouse a couple more times, I just want the names to show up. So as you've heard from Nadine, thank you, Nadine. It's a really good presentation, and you've covered all the information I think they've asked for. So that just really, I've sat here actually stunned and really interested in your topic. So thank you so much. Yeah. So I want to just offer some additional information around the scope of the project, what we're doing right now, and then what the plans are. As you've heard from Nadine, this is a pilot project. We're focusing in the north, on our north zone, primary care network of Grand Prairie, and then we're looking at Edmonton, which is we call Odamin, which is central Edmonton, and then we're looking here in Calgary with northeast Calgary with a PCN called Mosaic. And so we're working with those three partners, and then there's 3 DI sites that are linked to each one of these networks. Let's go to the next slide. So the lung cancer screening program is supported by Alberta Health Services with, as you heard from Nadine at the opening slide, with the Canadian Partnership Against Cancer. That's really sponsored all the provinces who are interested. And so you heard that this is going on in Quebec, it's going on in Ontario, British Columbia, full rollouts, and there's other provinces that are also in preparation or offering lung cancer screening, which is a really good news story based on what you've heard tonight. So in our plan, 22-23, up to 1,500 patients will be screened through that low-dose CT scan at our 3 Alberta Health Services DI locations, or diagnostic imaging locations. In our second year, between 2023 and 24, we plan to screen another 1,500 patients with also with those patients that are eligible for follow-up screens. And so by the end of the second year, we'll have a total around 3,000 screens offered. And as you heard, we do an eligibility assessment. And so we're really the program looks for patients who are between the ages of 50 and 74, who are currently using commercial tobacco, or they've quit smoking after using tobacco for 15 to 20 years. And we put them through a risk calculator, what we call a Tagamagi risk calculator, and they need to have either equal to or greater than 1.5 risk over 6 years to be eligible for the lung cancer screening. So a program also offers enhanced tobacco cessation. So we've actually had support from Alberta Health Services, just amazing. And so we've hired actually a therapist to be able to interview patients and look for ways to help them in tobacco cessation. Of course, the goal is to share those outcomes that we find in the next 2 years and use it as evidence to promote for a full provincial scale rollout so that we aren't restricted to 3 PCNs or three parts of the province. Let's go to the next slide. So this is basically a pathway. And I think I've heard you've talked about cervical, breast, and colorectal. And as you know, anyone who turns the age of 25 for cervical and then 50 for colorectal, and now you might have heard that they've just lowered the threshold from 50 to 45 for breast. And so anyone who turns those ages are offered an invitation to go and screen. Lung cancer screening is a bit different. And so what we're really doing is we're dependent on primary care providers in the community to know their patients. And in fact, that patient visits their primary care provider, they're assessed. And so that primary care provider will assess them for their eligibility, have a discussion around the lung cancer screening program, and then they'll determine if a referral should be made. And then that primary care provider actually sends a referral into the Alberta Lung Cancer Screening Program. The nurse practitioner, Nadine, will look at those referrals and then determine if they're eligible, and actually puts all the demographics and information around tobacco use, commercial tobacco use, and all the, there's a couple other factors that are considered as well. And then if they're eligible, then Nadine will go ahead and send an order to the particular diagnostic imaging center to book that low-dose CT scan for the patient. In addition, Nadine will also refer that patient who is using commercial tobacco to our enhanced tobacco cessation case manager. And the goal is to have them follow up almost like a triage and support. And so the goal is the majority of our patients are sent to this person to have a phone call and just to make sure that they're getting adequate support. And right now the program's able to offer Blue Cross support up to $500 for tobacco cessation supports. And so they really trying to make this program as successful as possible. And also studies, it's hard to explain everything, but of course, lung cancer screening really started in the UK, in the United Kingdom, and Britain, and what they showed there is that for people that were smoking, and as you know, as you saw, we were typically finding people late, but as you do lung cancer screening, you're able to find cancer much earlier. But the other caveat to this is people were quitting at a much higher rate when they were offered lung cancer screening. And so the theory is people are often in denial that they're using tobacco, commercial tobacco. And when you actually offer lung cancer screening in this phase here, when Nadine makes that referral to the CT program, that alone forces that patient to now think about themselves as a tobacco user versus sort of denying it and thinking that everything's going to be okay. And so in that whole effort to get them into a DI center, they stopped quitting. And so that tobacco cessation is a big part of this pathway in making sure that they have that support. They can have one-on-one support. They have group support. We have something called QuitCore. We have another department called AB Quits, and then of course Alberta Quits. And so there's different online or one-on-one, or also through their primary care network, they can get help from counselors and from support people or facilitators that can help them with their tobacco cessation. So once they go in and are scheduled for their diagnostic imaging low-dose CT scan, they're screened, and then that radiologist will look at the screen and to interpret it. And so you heard Nadine explain a little bit around that, that we have different what we call RAD percentiles or RAD designations. And so if it's a RAD 1 and 2, it really means that they're normal. And so some people will have some nodules, and there's actually a letter that goes out to the patient because they will get in-depth report from that radiologist explaining to them what their RAD report was, and they may get a little anxious that they heard they have some spots, but there's nothing to worry about. And so that is normal for most everyone. And then they'll be screened again for the next year. The second group is there's often inflammation or something going on, and so it's unclear. And so they'll have what we call a RAD 3 or 4A. And so in that case, we really can't make a determination whether they're a 1, 2 or something more severe that needs to be referred onto the oncology program. And so then we'll book them into 3 or 6 months. And all the patients in the RAD 3 to 4A category will actually get a call from Nadine, our nurse practitioner, and explain to them the results and what they can expect and what that interval in the next screen means. And then they go in and attend for that next screen for the 3 or 6 months. And then generally they're able to determine that they might either be upgraded to, unfortunately, a 4B or X. So that means they need to be referred on to the Alberta Thoracic Oncology Program, which is ATOP, or they just go and continue annual screening, which would be a good news story. Occasionally, there's something what we call incidental findings. And as you heard from Nadine, there's other cancers that can crop up, or it can go to other places. And oftentimes that low-dose CT scan will pick up something, a nodule somewhere else on the spine or on their neck. And so then the radiologist will make a recommendation for that primary care provider to review and deal with those incidental findings. Let's go to the next slide. So this is an example of the patient communication letter. We want to be as transparent as possible, and we want to let that patient reassure them that 90% of them will fall within that normal category, and they will just need to attend for annual screening. 7% of them, it'll be unclear, and so then they will need to be rescreened in 3 to 6 months, and we do reassure them that they'll get a call from the nurse practitioner, and then 3% of them will have an abnormal result, meaning that we need to do a workup. But that's at that point the exit screening, and we pass them on to the ATOP, or Alberta Thoracic Oncology Program. And Nadine will still call them, let them know what's happening and what the expectation is. And we of course also inform their primary care providers so they can support them in that journey as well. And then you heard Nadine talk a little bit about what they're doing as far as treatment for the different types of cancer they may be finding. So that becomes actionable. They can get quick care. And so again, we're hoping for better survivable rates, because essentially when they are diagnosed with a 4 beta X, we're discovering that way earlier, and somewhere where it's surgically resectable and preventable. Death is preventable in many of these cases. Let's move on to the next slide. So we do also work very closely with our primary care providers, and could not do this without their support. And so we do have a website, Screening for Life, and we do have information for care providers and also information for patients. And there was a big push from our partners to have this information up and running when we went live on September 1st. And so we provide, what this result is showing, the evidence, and I think we've heard that they're really happy with this information. And so this is a partnership, and so we're really excited to be here tonight to talking to you, because essentially we're bringing you on as a partner, and we're hoping in 2 years from now, when we go live provincially, we can come back to you and say, hey, let's promote this amongst your community and everyone who's at risk. And so that's a really exciting opportunity to be here tonight to tell you about this pilot, and also perhaps get ourselves invited back when we anticipate this to be provincial. And don't be afraid to talk to your MLAs and tell them, hey, we hear there's a pilot. We really want to see this go provincial in 2 years. And same as Saskatchewan, continue to advocate to your MLAs that this is an opportunity to prevent or to provide early diagnosis and stop having late diagnosis of cancer, which can be often fatal. Let's go to the next slide. Next slide. So the referral program is through our primary care provider. They will assess that patient for eligibility. We're looking at generally more than 15 pack years or more. And we don't look at pack years, actually. We look at number of cigarettes or a number of commercial tobaccos that's used. And then they fill out the referral form. They send it in. Nadine does put them through the risk calculator, and then we send them off with generally they will be eligible, but we do have some good news stories where they quit soon enough, and so they don't meet the risk criteria. The probability of getting cancer is fairly low, and so we don't even need to initiate this, because there is still a risk. CT scans do have radiation, and so if we don't need to put the patient through that risk, that would be actually better for the patient as well. So there is that component of risk that we want to consider. And so then we'll organize a CT scan and also make sure that all those patients are referred to our tobacco cessation support. Let's go to the next slide. So thank you again for this opportunity. I think we wanted to keep it under an hour, and we're 2 minutes on. I'm not sure if there's any questions, but thank you again for inviting us. And we're really pleased to be here talking to you about lung cancer and what it's about and how we can make it more survivable and support you, our partners, and all our patients.
Thank you very much, Nadine and Gordon. Actually, with your indulgence, we will spend another 10-15 minutes to answer some questions. And we do have one question here from Mr. Willie De Vera. Hi, this question is either for Nadine or Gordon. Just curious, is the AHS currently using artificial intelligence or AI or similar technologies to predict or diagnose lung cancer probability risk based off different variables or predictors? Thanks.
Okay, so I think the short answer, to the best of my knowledge, the answer is no, not at this point in time. And I'm wondering if you're thinking about, are we able to look at CT scans and have more of a robotic measurement of a nodule in the lung, et cetera. We're not there yet. Perhaps in the US that they're using some of these technologies. As you can appreciate, they're very expensive. And there's really no need for robotics with regards to screening. I think within surgery, they definitely do have different ways of performing surgeries. At this point, I don't know enough about what the thoracic surgeons would do, and I don't think they use robotics at this point, or perhaps they do in a modified way. That's probably outside of my scope of knowledge at this point.
I can also address, so I think maybe our viewer has a really good question, because in British Columbia, they are using AI to do some of the determination. In fact, their goal and part of this rollout is to continue to develop that. So in fact, these screens are read by basically a computer that can pull basically thousands upon thousands of x-rays or CT scans and look at them and then give a predictable response as to where it is in the threshold of risk, either 1 or 2, what we would define as a RAD 1 and 2, or a 4A or a 4XB to X. And in fact, BC is hoping that that AI will be developed enough to share across the provinces that it'll set the standard, but it's still in development, and they're very optimistic about it, but I think they're still dependent on the radiologist doing all the reads. But that is certainly the goal that BC has expressed, and so it's an interesting question for sure. And as Nadine said, it's very, very expensive. But we'll see. BC is hoping to be there and sharing it across the provinces. So it may be a good news story in a few years.
Thank you
I
very
did
much.
not know that, so that's good learning for me too.
Thank you very much. That was very informative. Another question from Stephanie: is lung transplant an option for patients diagnosed with lung cancer? How often has this happened? What is the recovery rate for patients who have had this transplant?
So lung transplant is not generally used for lung cancer. Usually what happens for lung cancer treatment is we look at removing part of the lung in some capacity, sometimes a whole, like, a lobe, or on occasion the whole one side has to come out, the whole right side. They don't generally transplant patients post lung cancer surgery because there's always a small risk that there were microseeds that are planted somewhere else. So we'd have to be, I imagine they'd have to be pretty convinced that that there's no risk of spread. But again, if they do that, it's very uncommon, and I have not seen that done in Calgary.
The other concern is when you do a lung cancer or when you do any type of transplant, you have to put them on autoimmune drugs. And so as Nadine said, if you're worried about nodules, what we are dependent on, in fact, our new threshold of cancer treatments is building up our immune systems to be able to fight it. In fact, that's where we're going as far as cancer therapy. And so you actually disable the very system that's designed to stop it. And so, yeah, you could transplant, but now you put the patient vulnerable, and the chances of developing cancer because there's no immune system is extensive, and in fact outweighs the risk. So that is always the risk of any transplant, is the fact that you're now putting the patient at risk for other cancers. We experience this with other we look at this with cervical as well. So you might do someone with a lung cancer transplant for another reason, for cystic fibrosis or something else, and then all of a sudden now we're facing a different type of cancer because they don't have an immune system, and it really becomes problematic.
Thank you very much. And following with this particular line of question, is there any developments in the usage of artificial lungs? Would this be a possibility anytime in the future?
I don't know anything about that, so I can't make a comment. I will, though, tell you that they're now looking at very specific blood markers to see if they can detect lung cancer without actually CTs and all the other investigations that we need to do. And there's a few studies that are ongoing here in Calgary, and I believe available to Albertans, except the challenge is that the testing has to happen in Calgary, so there's a lot of driving involved, and generally people are attached to a program But and hopefully we'll gain enough knowledge, and and these are international studies to try to figure out, can we detect lung cancer through blood tests? So if we can, that would actually be great, I think, in general for the whole population.
Okay. So do we have any more questions for our esteemed panelists this evening? I guess I would like to ask a question. Maybe some people are a little shy. Both of you mentioned that for lung cancer, it's mostly for those who are known to be smokers. But you also mentioned that there's also always this probability that lung cancer can also be had by persons who are not smokers. Could this have anything to do with their environment or their living environment that they are in, which might cause them to develop lung cancer?
I mean, there's definitely risk exposures to never smokers or people that have never smoked. Radon, secondhand smoke, being exposed to certain chemicals, especially if they are exposed to certain chemicals at the workplace. If you move from a different country and you've been exposed in your other country to hazardous biofuels, that can put you at more risk, particularly women, because they're often the ones doing the cooking over these biofuels. So yes, it's not, I mean, lung cancer in non-smokers is not as common, but unfortunately we can get lung cancer.
Okay. So another question is, what is the earliest that a person can be scanned? You mentioned that it has to be somebody about 50 years old or older before it's done. Can you actually scan people who have a family history of cancer at an earlier age than 50?
Generally no, because we do, there's not a lot of good data to suggest that if we scanned people ongoing, that we would be able to catch a cancer any sooner, a lung cancer. And I think the challenge with the lung cancer screening program, it's very different than the other screening programs. Like breast mammography, we want to look at, all women over the age of 45 to undergo mammography on a routine basis. And it's open to everyone. Well, lung cancer is quite specific to a very small demographic or a small population group. So to screen we couldn't afford to screen everyone. And we have to be mindful that we're using a low dose CT scan. It does have a radiation dose. So we want to be very careful that we don't start giving radiation through a CT scan to people that are young, because we know that it takes about 40 years to develop, potentially develop cancer from radiation exposure. But if you're like 30 and you're undergoing all these scans, then we are actually putting you at greater risk. So always the goal of anything in medicine is to weigh the risks versus benefits. And there's not enough benefit at this point in time to start scanning people earlier or to scan people that are never smokers, because it's such a small population that actually gets cancer.
Right. Okay, thank you. So here's another question from Anthony. Is it tobacco that causes lung cancer, or is it processed tobacco, which means chemicals included in tobacco? Most older people in our country, in Philippines, chew tobacco, but only a few have lung cancer. Most of them actually live above the age of 70.
Yeah, that's a good question. So when we think of tobacco, we think of cigarettes primarily, because most people that have tobacco exposure smoke cigarettes. Some people roll their own. We know, though, tobacco in general, the tobacco is a plant, and tobacco in general does have a number of carcinogen or cancer-causing agents within the tobacco itself. So we can't avoid or eliminate that. People that chew tobacco, smoke a pipe, those kind of people are more risk for mouth and throat cancers, because their exposure is all toward the front of their, in their mouth and down their throat. But when you think of lung cancer, we inhale the smoke into our lungs, and that's where the carcinogens land and over time create the damage.
All right. Thank you very much, Nadine, for that helpful information. And I take note of the time already, that it is 7:11 in the evening. And if there are no further questions, I would like to thank our resource persons and our audience for your very active participation in this webinar. May I once again call on the Consul General to deliver his closing remarks. Consul General, please.
Yeah, thank you, Vic. Well, again, I would like to thank our able speakers, Gordon and Nadine, for sharing their information with us. I think this has been a very engaging and informative session, an eye-opener for some of us. And I really would like to encourage our participants today to share this information with our community members, especially those whom we know are smoking tobacco. And also encourage at the same time people to stop from smoking tobacco. So until our next webinar, please do follow the Facebook page of the Philippine Consulate General. We have a lot of projects and programs for the benefit of our Filipino community. Tonight's webinar is just one of them. And I take on the suggestion of Gordon a while ago that when the rollout is already about to start, and during its implementation over the next 2 years, we will be pleased to partner again with Alberta Health Services in order to inform our Filipino community about this screening program that will be beneficial for all of us. Maraming salamat po sa inyong lahat at magandang gabi po. Please stay healthy. And for those of you na hindi po mababate later on, advance Merry Christmas sa inyong lahat. Bye-bye po.
Thank you, Consul General Patron. Before we end this evening's proceedings, may I request all our speakers and our participants to please turn on your cameras for our virtual group photo. May I ask Vice Consul Stephanie Cruz to do the honors?
Okay, again, may I request everyone to please turn on your videos? Okay. All right. 1, 2, 3, smile. Okay, one more. 1, 2, 3, smile. Thank you very much.
Thank you, everyone. And on behalf, once again, of the Philippine Consulate General here in Calgary and our partners from the Alberta Health Service, we thank you for attending this webinar. Stay healthy and keep safe. Good night, everyone.
Good night and thank you.